It's my great pleasure and honor today to be speaking with all of you about pregnancy with Friedreich ataxia. So I want to start just by going over a brief outline of the lecture, and if anyone has any questions as I'm speaking, feel free to stop me. I'll also take time for questions at the end. So we're going to be beginning by talking about planning for pregnancy and considerations when thinking about getting pregnant. Then we'll also talk about the common FA pregnancy complications seen. We'll review how Friedreich ataxia changes during pregnancy. We'll talk about additional medical care required during pregnancy. We'll go over the delivery statistics and complications seen. We'll also talk about how FA changes following pregnancy. And finally, we'll conclude with the psychosocial factors pregnancy. So far, 2 studies have evaluated pregnancies in larger cohorts of FA patients. The first was done in 1986 by Dr. McKenzie, and it looked at 17 women who had 17 pregnancies. The second study was a study we did here at CHOP, and it was published in 2010, and it looked at 31 women who had 65 pregnancies that resulted in 56 live births. And that study was a retrospective study. So we talked and interviewed with women and collected their medical records after they had already completed pregnancy. And the recommendations I'm going to make in this talk come primarily from these 2 data sources. So the first thing I want to talk about is considerations when planning for pregnancy. And the first thing is genetic testing for the partner. So as most of you are aware, Friedreich ataxia is a genetically recessive condition. So in this case, the mother would already be affected with 2 copies of the recessive gene. So whenever possible, it's important for the partner to get tested to see if he is the carrier of the FA gene. And if the father is not a carrier of the gene, there is no chance that the baby can be affected with Friedreich ataxia. The other thing to consider when planning for pregnancy is the age at the time of first pregnancy. So in the study we did here at CHOP, women said that in general they felt it was easier to care for younger children in the earlier stages of disease. So this is a slide that summarizes the common Friedreich ataxia pregnancy complications we saw. And in the middle column is the percentage it occurred in FA patients, and on the right-hand side is the percentage it occurs in the US general population during pregnancy. So the most common complication we saw was spontaneous abortion. Now, a full-term pregnancy goes to 40 weeks, and a spontaneous abortion is defined as a spontaneous loss of pregnancy before the fetus is viable, and this typically is considered 20 weeks. Now, most spontaneous abortions occur before 12 weeks. And the spontaneous abortions we witnessed occurred at an average of 8.17 weeks gestation, so fairly early on in pregnancy. It's important to note that all of the women in our study that had spontaneous abortion also went on to have healthy, successful pregnancies. And in the US general population, the rate of spontaneous abortion is estimated to be as high as 20%. So the rate we saw in FA subjects is largely comparable to the general population. The second most common complication we saw was preterm birth. Now, a full-term pregnancy is defined as anything greater than 38 weeks gestation. So we defined preterm birth as anything before 37 weeks. Now, in FA subjects, there was a 13% rate of preterm birth. And in the CHOP study, the earliest born baby was at 35 weeks, which is considered a late preterm, still with excellent outcome prognostics. In the US general population, the rate of preterm birth is roughly 12%. So again, we see that the complications seen in FA subjects are largely comparable to what's expected in the general population. Impaired glucose tolerance was seen in between 5 to 13% of FA subjects, and in the US general population, this occurs in as much as 18% of pregnancies. Now, in both our study at CHOP and the study done by McKenzie, 1 subject in each study went on to develop gestational diabetes. The remainder of patients with impaired glucose tolerance were they were treated just with dietary modifications, and they did not require insulin. The fourth most common complication we saw was pregnancy-induced hypertension. So this is high blood pressure that occurs during pregnancy. And this occurred in between 2 to 12% of FA subjects, and in the general population, this occurs between 5 to 7%. And the final complication we saw frequently was the development of preeclampsia. And preeclampsia differs a little bit from pregnancy-induced hypertension in that in addition to the high blood pressure, you also see some protein in the urine, indicating that there is some kidney involvement as well. And this occurred in 4% of FA subjects, and in the US general population, we see it about 5% of the time. So the main point to take away from these slides is that there were complications seen in pregnancy, but none of them occurred more frequently than what happens in the general population. Yes, is there a question?
No correlation with
Low fluid.
amniotic fluid.
For which complication? So the question is, was there any difference in pregnancy for people that had low fluid levels? And we did not see any difference. Any other questions? Okay. So the main takeaway point again is that the complications we've seen were roughly the same as the general population, suggesting that FA in itself does not predispose to further complications. So in our CHOP study, we asked women to tell us how they felt that their Friedreich ataxia changed during pregnancy. And 29% of women said that they felt pregnancy made their disease better. And they often said that they felt more grounded on their feet and that they had better balance and coordination. 36% of women said that they felt pregnancy made their disease worse. And they often reported increased fatigue, more urinary difficulties, including increased urinary urgency and frequency, and further speech, balance, and coordination difficulties. Now, the remaining 35% of women said that pregnancy really did not change their disease, and they didn't think that it was better or worse. So I want to talk now about the recommended additional medical care during pregnancy, and I want to make two notes. The first is that this is additional medical care, in addition to the care that all pregnancies in this country receive anyway. And the second is that these recommendations are not based on observed complications in FA, but rather on a general need to be conservative. So the first thing we recommend is strict glucose tolerance testing. Now, Friedreich ataxia patients in general are predisposed to the development of diabetes, and although we did not see an increased risk of gestational diabetes, we still recommend routine glucose tolerance testing to be performed between the 24th and 28th week of gestation or earlier for those individuals who are deemed to be at high risk by their obstetrician. The second thing we're recommending is neurologic exam testing. And this is to allow changes in the Friedreich ataxia disease state to be monitored prospectively. So this can be done by a trained neurologist using scales that many of you are familiar with already, such as the Friedreich Ataxia Rating Scale or the International Cooperative Ataxia Rating Scale. And this just allows for the quantitative tracking of the neurologic disease changes. So right now, all of our data that we have collected is retrospectively, and we haven't yet been able to follow women prospectively as they're pregnant. The other really important piece of medical care during pregnancy is cardiac management. And as many of you know, in general with Friedreich ataxia, you're predisposed to the development of cardiomyopathy, atrial fibrillation, and other cardiac abnormalities. That is why close monitoring by a cardiologist during pregnancy is essential. And this can include a variety of tests at the discretion of a cardiologist, including echocardiogram, EKG, and Holter monitoring, and others. So this is a slide which I borrowed from the European Heart Journal, and it just briefly summarizes the hemodynamic changes that occur during pregnancy. So during pregnancy, a mother's total blood volume increases by roughly 50%. And her cardiac output, so how much blood her heart is pumping out, increases by about 30 to 50%. So pregnancy is a condition where the heart has to work extra hard. So just to give everyone a little bit of background about why we worry about the heart in pregnancy and why it's extra important to take care of the heart during pregnancy. So this slide presents some guidelines which I borrowed from the Task Force on the Management of Cardiovascular Disease During Pregnancy. And these guidelines were published by the European Society of Cardiology in 2011. So the guidelines state that the presence of hypertrophic cardiomyopathy does not automatically classify a pregnancy as high risk. And that oftentimes the pregnancy is low risk if the hypertrophic cardiomyopathy had been previously well tolerated prior to pregnancy. So research has shown that the degree of left ventricular outflow tract obstruction determines risk during pregnancy and delivery, with a higher outflow tract obstruction correlating to a higher pregnancy risk. So one thing the guidelines do note is that dilated cardiomyopathy or an ejection fraction less than 40 is typically considered high risk, but that just hypertrophic cardiomyopathy does not alone classify a pregnancy as high risk. So now I want to talk a little bit about the delivery statistics that we saw in our study at CHOP. So in our study at CHOP, 78% of all births were vaginal, and 22% was cesarean sections, including 2 elective sections. So in the US general population, the rate of cesarean section is estimated to be between 25 to 35%. So we actually saw a higher rate of vaginal delivery in FA patients compared to the general population. 87% of babies were born at term, which I said is considered between 38 to 42 weeks. And 13% of the babies we saw were born preterm. And these babies were born between 35 to 37 weeks, which is considered a late preterm. Now, in the McKenzie study, which had looked at the 17 pregnancies, all of those babies were born after 36 weeks. So in our study at CHOP, the average birth weight of the babies was 7 pounds, 8 ounces, and 89% of all babies were a normal weight, which is defined between 6 to 9 pounds. So the average length of hospital stay for the mother and baby following delivery was 2.6 days. And in the US, the standard of care for a mother and child following a vaginal delivery is to hold them 48 hours, and following a cesarean section is to hold them for 96 hours. So the length of stay is roughly on target with what we would have expected. And in the study at CHOP, 94% of babies were discharged home from the hospital at the same time as their mother. So from both our study at CHOP and the McKenzie study, as well as other case reports in the literature, there are successful reports of the use of both spinal and epidural anesthesia during delivery and labor for pain control. Now, one thing we've heard anecdotally from a few of our patients is that if you've had the scoliosis correction surgery and you have rods, it can be helpful to have an anesthesiology consult beforehand, just to talk about how the rods might affect catheter placement. In our study at CHOP, we found fetal distress as a complication in 7% of laboring mothers. And in the US population, this is reported to be at around 2%. So we aren't sure why we saw an increased risk of fetal distress. One thing that we do note is our sample size was relatively small, and a larger sample size would be needed to confirm that this is a true finding. But for now, we recommend that the baby just be closely monitored during labor and delivery. So we also asked women to tell us how they think their FA changed after pregnancy. And 50% of the women we spoke to said that they really didn't think their FA changed one way or the other. 7% of women said that their disease improved, and although they thought it improved, they really couldn't tell us how. And 43% of women said that their FA became worse, and the number one reason we heard was that they were more tired. Now, it's important to keep in mind that these women also had a newborn at home, so some fatigue is expected. We also heard that women experienced more urinary urgency and balance difficulties following delivery. And some women did tell us that due to their balance difficulties, they were very initially scared of dropping the newborn. So at CHOP, we also focused on the psychosocial factors of pregnancy. So what led the women to get pregnant, and how did they feel about their Friedreich ataxia in relation to their pregnancy? And 52% of the women we spoke with said that Friedreich ataxia had a large or moderate impact on their decision to get pregnant. 53% of the women we spoke with were concerned about a shortened life expectancy due to Friedreich ataxia. And we heard many stories from mothers about how they made special accommodations for their babies. One that I remember in particular was a mom who went shopping for a crib with her physical therapist to find a crib that would be wheelchair accessible. However, the majority of women we spoke with all felt that their children benefited from having mother with Friedreich ataxia. And we heard many times over that they felt that their children were more sensitive and caring towards the needs of others, and that they tended to grow up more with the bigger picture of life and sort of were able to let the small things go. So I want to talk about briefly how to choose an OBGYN provider. And the number one thing I want to stress is how important it is to find a provider that's supportive. So we heard many stories from women who would go to their OBGYN and say, I think I'm ready to start having a baby. And the provider would tell them never to think about that with Friedreich ataxia. We even had one patient who was told by her OBGYN that she should find someone else to care for her baby because she would never be able to do so herself. So we know that's not true. And I cannot stress enough how important it is that the provider be your biggest advocate and the one cheering you on and on your team. So if a provider says something like that to you, it's time to find another provider. The other thing that's really important is to have an interdisciplinary care team. So you, of course, need the obstetrician gynecologist who's sort of spearheading it, but you also need to have a cardiologist and at bare minimum a neurologist. And these people really need to work together to coordinate the health of the pregnancy. And as needed, you might also need anesthesiology, endocrine, or maternal fetal medicine. And I wanted to mention briefly that there's new Friedreich ataxia clinical guidelines, which are soon going to be available for providers. And the Friedreich Ataxia Research Alliance has done an unbelievable job of putting these together. And there is going to be a section on pregnancy specifically available. So this is some questions to ask when you're meeting with a provider for the first time. The first thing is, have you ever cared for anyone with a neurologic disease during pregnancy before? And what do you know about Friedreich ataxia? So OBGYNs are experts at babies and deliveries, but many of them will have never heard of Friedreich ataxia. And that's okay, but it's important to assess where your provider is coming from when you first meet them. And it can be your job to work with them to help educate them more about FA. The other thing you want to find out is, are you willing to work collaboratively with other providers to comprehensively manage my health and the health of my baby? So as I said before, that interdisciplinary care team is so important, and the OBGYN really needs to be the one spearheading that. And the last thing is, are you willing to read the literature regarding the best management of my pregnancy? So at this point, there have been a number of studies that have looked at Friedreich ataxia in pregnancy. And it's really not acceptable to have a provider tell you there's no data on it or it's a terrible idea for you unless they're up to date with the literature. So I sort of want to conclude some of the things I've talked about. The first is that a vaginal delivery can be expected of most pregnancies, and it is the preferred delivery method whenever possible. It's the best way for both the mother and the baby. The majority of babies we studied were born at healthy weights, and they were discharged home with their mothers. We do recommend close fetal monitoring during labor and delivery, and we have seen that both epidural and spinal anesthesia can safely be used. So from our research, what we've found is that under most circumstances, pregnancy in Friedreich ataxia does not need to be considered high risk. And women with FA should be encouraged to proceed with pregnancy if they wish to do so. And at this point, I'll take any questions. Thank you.
I would amplify two things. First of all, Lisa's acting as a nurse practitioner in an OBGYN practice right now, so she actually is quite expert on this. I would also mention that over the past year, we've actually been managing 4 individuals with Friedreich ataxia who have been pregnant and delivered successfully. Actually, 3 have delivered successfully, the 4th is not quite due yet. So it is not as rare a situation as people would have you believe. Great, Lisa, thank you.